In some countries, patients are sent to a centralized center just based on a diagnostic TUR. So then the tumor is resected just to make the diagnosis, not with the intention to do a deep and complete TUR. And then if you do a re-TUR in the center, of course you find a lot of tumor. I referenced a few guidelines references during my presentation where you see that, let's say 30 to 50% of patients that have a re-TUR still have tumor on the same place where the initial tumor was. I don't think that has been a good resection. So I argued that if you do, as a urologist, a good resection, maybe helped with blue light or with a lot of experience, and you are sure that you did a good resection and your pathologist confirms that, so your pathologist says, yes, it's a T1 tumor, we have muscle in the specimen, the muscle is negative, then I think you could defend not doing a re-TUR in T1 cases. I've checked that in my own hospital, and indeed in my own hospital, my own series, there is no additional value of re-TUR. The disadvantage of a re-TUR, that it is an additional surgery in predominantly older people, in frail health, they are smoking, they're not optimal. You will postpone effective therapy like BCG therapy for 1 to 2 months. So there are also disadvantages to a resection. So I think it's of course not black and white, and if you're in doubt, do a re-TUR because it is guideline. But if you are not in doubt and your pathologist is not in doubt and you've did a good job, I think you can defend not doing a re-TUR. Well, I referenced something yesterday, I think, a very funny study where they put in a caval filter during TUR in only 7 patients, because it's of course a very delicate study that they have done, and in 6 of those 7 patients they found tumor cells in the caval filter during TUR, meaning that if you cut through the tumor, what we do, you do induce spread of tumor cells. So every resection has the risk of, let's say, maybe spread of tumor cells. I don't think that's really proven yet, but there are certainly theoretical disadvantages, apart from the fact that the patient has new anesthesia, there might be a bladder perforation, they have to come into the hospital again, etc., etc. The history is funny. I'm colorblind, so the company that invented the blue light system asked me at the beginning of the century whether I would work with that, because they thought if he sees it, everybody sees it. And I always tell it's pink and blue. I don't see it as pink and blue, but I do see the difference. You do get a better image of tumors. You do actually improve your resection because you see it better. That's then as a cause you have less recurrences and a better outcome. So for me, I think it's a no-brainer that blue light really improves your resection skills. It has no side effects. So for me, it's something I use a lot. I bought, I think 2 decades ago, on a market in Belgium, a cystoscope from the American Cystoscope Company in a beautiful wooden box from 1921. And that cystoscope looks exactly like the one we use now during TUR, only with a small lamp on the end, a real lamp. So in those days, cystoscopy was done with air and not with fluid, because if you put fluid around the lamp, you will have, of course, you call it a shortcut, or at least your patients will be under current, and that's not a good idea. And nowadays, I still sometimes, if I do a cystoscopy and there's a lot of bleeding, you just take out the fluid, put in air, with a syringe, just put in air, and you have a perfect image of what you see in the bladder. It's very simple, and it's very old-fashioned, but it's very simple and effective.